and COVID-19. So let us start a discussion. The basic gist of the idea here is that the children are fortunate, which makes us adults fortunate as well, because it is difficult to see a child going through a difficult state, and child death is very, very tragic. So fortunately, the prevalence of the disease in the children and the intensity of the disease in children is very low. Death rate is very low, and we are going to look at some studies today to see how that happens. And this is actually a good news. So let's start. And as we start our discussion, I also wanted to share that somehow YouTube decided to take down the remdesivir mechanism of action video that I had done. I think some folks who were not very happy that remdesivir is approved, they kept going and flagging my video as inappropriate content. Imagine that, remdesivir mechanism of action as inappropriate content. And because they flagged it, YouTube this morning notified, the video is removed, and it just says, your content is removed for being inappropriate according to our community guidelines. So that was just, as much as it is stupid that they did that, it is weird as well that people at this time of a pandemic, when it is necessary for all of us to come together to find solutions to save lives, people are still being political. They are still going and taking out videos, educational videos, and just saying that, hey, I don't like this content, it is inappropriate. So that is weird. Anyways, let's start our discussion today. For this discussion, I want to give a disclaimer. There is no sponsor of Big Pharma or Little Pharma to us. This is my independent, unbiased expert opinion and presentation. No one is sponsoring this talk. So with that, hello guys, how are you? Yeah, so it has been used, and it is also approved now by FDA, and YouTube just decided to take it down. So that was weird. Anyways, so let's start. The discussion is very important for today. Children and COVID-19. Most of the discussion is actually good news out of this dark time in the pandemic when adults are at risk and people with advanced ages and comorbidities are at risk. At least our children are safe, or much more safe than us are. So let's look at them. So here we are. So I spent the whole day today, good morning guys, to make these cute little cartoon shapes for us, because the topic is very interesting and a little bit happier topic as well. Even I felt a little more comfortable and happy compared to other daily gloomy discussions that we do. So the SARS-CoV-2 and COVID-19, and you guys are very, very welcome. Thank you very much for your time as well, that you come and join me. I actually believe that we are all learning together. We are all doing something that is useful together. And at this time in the pandemic, it is even more important that we are coming together and working together and learning together. So let's keep doing that, and we'll go from there. And I'm sorry, I can't show everybody's comment, so don't mind. I want to tell you the CD said that word face coverings, not masks. Got it. Yes, so Terry, I actually read that. But still, did the WHO, White House's site also said that? I read in the CDC today, they use the word face covering, and that is good. All right, so let's start. So children, first, fortunately, the outcomes in the children are much better than adults. And here, when we talk about the children, the age range in various studies is going to be from fetus to, that means still intrauterine, to 19 years of age. And different studies had different age ranges, but this is the normal age range that I'm seeing in various studies. Welcome, guys. So let's see. First important thing, studies have shown and these studies I'll show you, that there is no proof of vertical transmission yet. That means a pregnant woman has not been shown to transmit the disease to her child while the child is in her uterus. So that vertical transmission is not observed so far, which is again a very good news. Similarly, the second important thing is there is a study done on 9 women, and they did not find any coronavirus transmission through the breast milk. So that is also a very important and very good outcome. So these, I wanted to make sure that right in the get-go we talk about it. The CDC still says that even when the breast milk does not transmit the coronavirus, still a COVID-19 positive mother and a COVID-19 negative child, they still need to make sure that take as much care as possible. So CDC has a bunch of guidelines for how to protect the child who is COVID-19 negative. So these are two good things right off the bat. So now let's see here. There is a study I'm going to show you as usual. So here is the study I'm referencing. So this is the children with COVID-19 in Pediatric Emergency Department in Italy. So this is published in New England Journal of Medicine. And the publication date, I believe the study was done between March 3rd, if you see here, March 3rd and March 27th. So what did they find? Number one, really good news. They found that only 1% of the confirmed cases were children. 11% of these children who were confirmed were admitted to hospitals, and no deaths, which is excellent. I love it. Some good news in our daily tragedy that we go through. So 1% of all cases in Italy, when the study was done, were children. So that is a very small range. Good. 11% of those 1% were admitted to hospital. So that means a smaller percentage became sick enough to go to hospital, and then there were no deaths. So if you look at this study, I have some data here, but I want to show you that data in this graph here. So in this graph, if you see so they took 100 children to do this study in Italy. And what they found was that about 12% of the children, so look at this one first, 12% of the children appeared ill. And with this discussion today, keep an eye on the asymptomatic patients. That is a very important group of the children, because asymptomatic patients can be shedding while they are asymptomatic. The other thing that is interesting to note is that more than 50% of the children, so I'm going to side note back here. So this study was on 100 children. Median age of the children was 3.3 years. That means 50% of the population on which they did the study, they were about, age was 3.3 years. This is very, very interesting. Look at this. 55% of the children were exposed to the infection outside of their family, meaning from outside, or they, or they could not find out where did they get the infection. So this is why I am actually against the opening of the schools first. And I'm seeing that many of the countries that are opening up their or easing up the lockdown, they are opening up the schools first. I don't believe in that because of the two reasons. Number one, children could be asymptomatic and they could be receiving the infection. See here, 55% of the children received infections from outside of their home, and then they can spread it. That's one. Secondly, any tragedy with the child, I think, is a situation that is heart-wrenching for their parents and family for the rest of their life. So that risk is not worth taking. And both for children to become contagious and asymptomatic, and for parents to put their children at risk. So I do not believe in opening the schools first. So back here, 55% from outside, 12%, so back here now, 12% appeared ill, 54% had fever. So fever and cough was the most common observation. 44% had cough. Then this is an interesting one. 23% had feeding difficulty or could not feed at all. So that is a difference from adults, where feeding difficulty may not be a very prevalent or common symptom. And then fever, cough, and shortness of breath together, 52%. 4% of the patients needed oxygen. They had oxygen saturation issues and needed support in hospital, either with the oxygenation or with ventilation. So no, Siddhartha, good question. So the question is that, do they get loss of taste or smell? So no. And I think this is a more later observation. Maybe people were not even aware at that time to ask this question. So this is a study that was in March. So maybe patients had it, and maybe children can actually not tell as well. A 3-year-old may not be able to say that, hey, I cannot smell or I cannot taste. So that may be a data element that was missed. But at least from the study point of view, your question's answer is no. And Brandy, it is very, very correct that it is really the loss of smell that then causes the, and you're right, it is possible that their difficulty in feeding may be because of the loss of taste and smell. And please remember this, that whenever we talk about loss of taste, it is really, in case of COVID, it is really the loss of smell, which occurs because of the inflammation of the olfactory nerves. So when olfactory nerves swell up, that causes the loss of smell. And we know that the flavor is composed of smell or fragrance of the food plus the taste of the food. So when the fragrance of the food is gone, the smell of the food is gone, and only taste is left, we do not recognize it as a correct taste or flavor, and we say, I cannot taste well. So there is no damage to the taste buds or the nerves for the taste. It is really the damage is to the olfactory nerve, or the nerve that is used for smelling, and the taste is a consequence of that. So back here, 4% needed oxygen. So here, what they did was they took this staging of the disease. The staging of the disease is asymptomatic, mild, moderate, severe, and critical. And let me show you that this staging is here. This was done by Dong et al. In their own study of children and pediatric population. And here, this is what the staging was. And this is important. Look, asymptomatic is very important in the children's categorization. So asymptomatic infection, where the patient had no signs or symptoms, but they were testing positive. So that is asymptomatic. And if you see here, in case of Italy, 21% of the children were asymptomatic. Now, these asymptomatic children may be shedding while they had the virus. In case of another study from China, which was done by Dong et al. Here, they found that 4.4% were asymptomatic. So we'll come back to this in a second. Let's look at the criteria. So asymptomatic is asymptomatic but positive, mild. So general way to understand the symptoms, signs and symptoms in children is that most of the signs and symptoms are for the upper respiratory tract infection. Children luckily develop less lower respiratory tract infections. So if you look at mild, so they have fever, fatigue, myalgia, cough, sore throat, runny nose, and sneezing. No auscultatory abnormality. That is the important part of the mild stage. That when you are listening to their chest, the chest is clear. And they may have a varied number of symptoms: fever, myalgia, sneezing, cough, and they may even have nausea, vomiting, and abdominal pain and diarrhea. So there may be GIT symptoms, there may be upper respiratory tract symptoms, but chest is clear. That is the mild one. Then the moderate. In the moderate, pneumonia has started. So that means the virus has gone down into the lungs. Pneumonia has started. When you auscultate the chest, you may hear wheezing, but generally the patient does not look that bad. So there may be still cough present. Cough may be productive. Remember, this virus, we've talked about it many times. It starts with atypical and then it can become productive, which is usually a typical pneumonia done by bacteria. But here this virus can do that too. So some cases may have no fever or have only digestive symptoms, such as nausea, vomiting, and abdominal and diarrhea. And we know this, that in adults, about 4% of the adults could have just the digestive symptoms. So here, the same thing. So that is moderate. So what is interesting in moderate is that you may hear something in the chest. Pneumonia has started. Then is the severe. Severe is when the fever and cough and GIT symptoms may be present, but here is, check this out. The central cyanosis and oxygen saturation of lesser than 92% with the manifestations of hypoxia. What does that mean? There may be tachypnea, there may be tachyarrhythmias, tachycardia. So the hypoxia has set in, central cyanosis is observed, and other manifestations of hypoxia can be seen. And that it's not necessary that the fever is there. If you see here, fever in most of these patients was intermittent. It will come and go. And that is a very interesting outcome as well, or an observation as well. Critical cases is when the acute respiratory distress syndrome develops. And patient may go in shock, encephalopathy, myocardial injury, or heart failure. Coagulation dysfunction. So look, we are kind of making our noise now that, hey, there are hypercoagulability. This is a study from March from China, and they said coagulation dysfunctions may be seen, and acute kidney injury may be seen. Organ dysfunctions can be life-threatening. In this study from Dong et al. That I'm showing you here on the screen, one child died. Their number of children were 2,135. I think 1/3 of them were confirmed cases. 2/3 were suspected cases. And we all now know that suspected cases, I think we've discussed it many times. What is a suspected case? Can anyone tell me? So Cheryl, is there a significant number of reflux issues with the children? So yes, those children, see this 23% of the children that are having feeding difficulty and no feeding, they may have these symptoms as well. Interestingly, I did not see a very clear-cut description of various kind of signs and symptoms in these studies. So can somebody tell me that what is the definition of a suspected case? Symptomatic with RT-PCR. No, so that without RT-PCR. Well, that is a presumptive case, that is correct. But the way WHO decided was symptomatic, which is correct, that you said. Symptomatic plus they have been in contact with a COVID-19 patient, positive patient, or they have been from an area of outbreak, known outbreak of COVID-19. So if somebody has the symptoms and they are in contact with a COVID-19 positive patient, or they have symptoms and they have been from the area of outbreak of COVID-19, then that is a suspected case. So back here in this study, Dong et al., they had said there were 2,135 patients in which about one third were confirmed, other 2/3 were suspected cases. Out of all of them, 2,135, there was one death. I do not want to use the word only one death, because even that one death is going to be tragic. It was a 14 years old child, but compared to adults, this was the situation. In the case of Italy's um, study, 100 children, no death, zero death, no death. And look at this, asymptomatic 21%. This is the reason I don't want the schools to open yet. Mild cases 58%. So look, upper respiratory tract like symptoms are what? 58 plus 21. So almost 80%, correct? 79%. So majority mild cases. And this is the takeaway for the pediatric generation, or for the patients, that most of their illnesses are mild. 19% moderate, and then 1% severe and 1% critical. And then all of them recovered. That is a good news. So there is a question, if a family member is a child, is he or she less likely to get infected compared to adults in the same family? I do not know about that. What they have said was that when a child is present, 45, see here, 55, so 45% of the infections in, in the children were received from their family members. 55% of the infections were from outside or unknown sources. So back here. Now there is a difference. Look at this. The symptomatic patients in the Dong et al. Here and the symptomatic patients here. The mild cases here and the mild cases here, they're different. And the Italian study said that the reason we felt that these were mild was that we were testing with the CT scans less, or MRIs with less frequency. Because of that, they were doing more of a clinical assessment or a chest X-ray assessment instead of MRIs or CTs. So maybe if they were doing computer tomography, then they may have seen more cases of pneumonia or ARDS developing, and they may have categorized them as moderate. So from that statement of theirs, I felt that what they're saying is that this is the Dong et al. This is a better representation of the children's case compared to what we are seeing in Italy. So any questions so far? Before I go to the next stage, I want to talk about the COVID toes and Kawasaki disease. Okay, so I think we are good so far, correct? So let me just show you the studies as well. Here is the Dong et al.'s study. I'll put the link later on. Here, this is another review of their study. This is in the Pediatric as well, American Academy of Pediatrics. It is also published there. This is a study of multiple, it's an article about multiple studies. And their conclusion has been that number one, children can be asymptomatic. Number two, children can develop the coronavirus presence in their fecal material even after a couple of weeks of developing symptoms. And what they wondered, they are not sure, so that is here. What they wondered is the fecal oral route possible? So from my previous studies, which I have seen, fecal oral route of transmission is possible, and children are one more important vector for fecal oral route, because if they are not potty trained or toilet trained, or if they are too young, then the parents may be coming in contact with their fecal material more often, and that may be another way of transmission. Another interesting thing in these studies, which I think is really important, is that children lesser than 1 year of age seem to have a more severe disease compared to other children. And the reason for that seems to be that their immune system is not as mature yet. Immune system is not as mature. And because of that, they tend to have more severe illness compared to the children after 1 year of age. What about public pools in the summer? Will bromine and chlorine kill the viruses? And ideally, yes. Asymptomatic are worst sharers. So spreaders, we can call them super spreaders. But this is important for children not to go back to schools yet until we have a better control of the society's discipline for reopening. Okay, so let's talk about the Kawasaki disease. So here, there have been some reports, and I want to show you this. And I want to also talk about this. We think that somehow Kawasaki disease is something new observation with the coronaviruses. Look at this. This is, I believe, UK's National Health Service, or NHS England. They had this little tweet which people were very angry about, because they simply said, we are seeing a rise in Kawasaki disease in children of COVID-19 positive cases. But they had no data there. That was it 1 out of 100 or 10 out of 100, or is it 1 out of 100,000? Nobody knew. The word was just simply rise in cases. So people became really upset. If you read this thread, they kept asking that what kind of information is this where we have no takeaway from it. But generally, this is an observation in UK that children were becoming ill with Kawasaki disease as well. So I did some digging and I found out, this is another one. So I found out, check this out. I believe this is 2005. Look, 15 February 2005. 2005. We are talking about SARS-CoV-2 now, right? So I did some digging and I found out that association between novel human virus and Kawasaki disease. There was a paper then for SARS-CoV. That was the first time the SARS. Remember the virus. The history of this virus is that it was in 2002 to 2004 in China, there was the first outbreak that was named as SARS-CoV, correct? Then in 2012, there was another outbreak in Saudi Arabia that was called MERS, Middle East Respiratory Syndrome CoV, and this was severe acute respiratory syndrome CoV. And now in 2019, we have the SARS-CoV-2. So this time, they actually did a study and found out that the Kawasaki was possible even at that time. So we should have been a little bit more prepared, or at least aware that this could have happened, instead of saying, hey, we are seeing this new phenomena. So here is a study, association between a novel human coronavirus and Kawasaki disease. And here they're saying, so this is, they're talking about Kawasaki, I'll discuss that in a second. But what they're saying is that 72% of the confirmed cases in this study, there were 53 children who had received a diagnosis of Kawasaki positive disease. They took their data, and 72.7% of the cases were positive for COVID-19 as well. So this association of the Kawasaki disease with the children has been observed before. So what is the Kawasaki disease? So it is a disease of unknown etiology. We know what happens, but we do not know why does it happen. Speculation is that this happens because of viral or bacterial infection. So what happens is, here is how we diagnose Kawasaki. Fever for 5 days or more, plus out of the following criteria, 4 of the signs or symptoms. So what are these? Bilateral conjunctivitis. So eyes, bilateral conjunctivitis. That is one. Erythema of the mouth. So redness in the mouth and the tongue, and the pharynx is red as well. So erythema of the mouth or pharynx, strawberry tongue. The tongue is really red. And then stomatitis, swollen as well. Then polymorphous rash. So there is a rash there are rashes on the body, and they could be varying shapes. Erythema or edema of hands and feet. So hands and feet may be red and swollen. So if you Google the pictures, I don't want to show them here because of the copyright issues, but if you Google the pictures, you'll see actually the swollen and red hands, and you would see lots of rashes on the body. and then non-suppurative cervical lymphadenopathy. So here, lymphadenopathy may be there, cervical, and it may be unilateral. It may be bilateral or unilateral. So this is the Kawasaki disease, the signs and symptoms. Or it is possible that you have 3 out of these 5 plus the coronary artery abnormality. And let me now explain what really happens, at least what is the pathology observed. What is observed is that it is a vasculitis. That means that the blood vessels become inflamed. And when the blood vessels become inflamed, most common blood vessels that become inflamed in the Kawasaki are coronary blood vessels, the heart's blood vessels. So when the coronary blood vessel, so let's say this is our heart or child's heart, when the coronary blood vessels become inflamed, what happens is there are a couple of things. Number one, aneurysm develops, and please do not throw stones at me for spelling. I think this is the right spelling. Aneurysm of the artery develops, so like this, and massive aneurysm. And then, of course, it is possible that with aneurysm, there may be rupture as well. And the result is there can be ischemic heart disease. And we're talking about children greater than 3 and lesser than 5. So young children, they might develop ischemic heart disease or they might develop infarction. There may be even sudden cardiac death. So that is the most dangerous outcome of the disease. Let me close some of the things here. Maybe that would help. If it is buffering, is it buffering for everyone? Are you able to hear this? Good morning. Okay, so this is the Kawasaki disease. What it does is it causes the inflammation of the blood vessels, normally large and mid-sized blood vessels, but it can actually cause the disease in smaller vessels as well. And keep an eye on that, because that may be the reason the smaller vessel disease of the COVID toes. Okay, so check this out. Here is a blood vessel. What I did was I opened it up and I have the blood vessel's internal surface here. These are the squamous endothelial cells. When they see the Kawasaki disease, in the acute phase, they see a lots of neutrophils. And these are going to cause inflammatory reaction and damage to the tissue, especially the vessel wall. In addition to that, they also see a lots of helper CD4 cells. They see a lots of cytotoxic CD8 cells and the plasma cells, which are active B cell making immunoglobulins. And these plasma cells primarily are making IgA immunoglobulins. They also see dendritic cells. All of these cells sitting in the vessel wall are causing inflammation and damage to the vessel wall. Because of that damage, so that is the Kawasaki disease. So there is fever plus damage to the vessel wall, resulting in these signs and symptoms. This is the Kawasaki disease. Normally, it is self-limiting, but because it is life-threatening as well, immunoglobulin therapy is given, and then aspirin is given, and patient usually recovers. So that is the Kawasaki disease. Let me show you a little bit of the mechanism, immune mechanism, and I have to share this funny thing. I usually make the immune mechanism like this. Here is a macrophage, correct? I've probably done it so many times. And macrophage then connects with a T cell, which is a helper T cell. And macrophage is presenting the antigen, and helper T cell connects with it. And then there are co-stimulations. And then helper T cell, if there is interleukin 4 available, then it becomes T helper 2, and then T helper 2 releases IL-4 and IL-5, which causes B cells to become active. B cell activation, correct? Active B cell are called plasma cell. And then if there is interleukin 12, then the helper cell becomes T helper 1 cell. So this is naive helper cell or 0, T helper 1 cell, which in turn then causes the cytotoxic T cell, which is also called CD8 cell, CD8 positive cell, which is a cytotoxic cell. So I've been making it many times. In two of the videos, I made a mistake. In one video, instead of writing T helper 2 above and T helper 1 below, I actually wrote T helper 1 in both places. And then in another one, I had my mouse cursor here on T helper 1. What I was trying to say was, this is the cytotoxic pathway. And my mouse cursor was here, and I said, this is the cytotoxic cell. And someone became really upset on YouTube and said, how dare you call a CD4 cell? These are CD4 cells, CD4 positive cells, CD4 positive. This is CD4 positive. He said, how dare you call them cytotoxic? Cytotoxic are CD8. And I said, yeah, I know that, but maybe my mouse cursor was in a wrong place. Anyways, in the Kawasaki disease, what happens is, let's say we have COVID, we have SARS-CoV. When SARS-CoV comes in, what it does is the presence of the pathogen leads us into this pathway, and cytotoxic T cells become active. And you know that normally this pathway is not right for COVID-19. But these cytotoxic CD8 cell becomes active. They are the ones that are present here. They are the ones that are present in a large abundance. And they're causing local damage. The second thing is, we know that COVID-19 ideally should cause this pathway as well. Sorry. And the B cells, they make IgM, then they make IgG, and then they do class switching to make IgA. We have done this discussion in immunology lectures many, many times. The B cell they found in the blood vessels are called plasma cells, and those that are making IgA. So IgA with the cytotoxic T cell is a marker, or is a composition for the viral infections or intracellular infections. Because we have discussed this in the past, that it is a CD8 cell and the natural killer cell that would help kill the cells that are sick with the virus in them. Remember we talked about it, that the cell that is sick with the virus cannot demonstrate enough MHC1 on its surface and other cluster of designations, which causes the natural killer cell to recognize that this virus is sick and kills it. Similarly, CD8 cell can connect with such cells if they are exhibiting something on this MHC1, and then they can kill this cell as well. So the point is, in the Kawasaki disease, there are more cytotoxic cells, plus there are IgA producing B cells. So the question is, hey man, we got the cytotoxic cells doing the function. Why do we have B cells producing IgA? IgA is produced to go and live in the mucous membranes, that is the wet surfaces of our body, and they try to bind these immunoglobulins, try to bind the viruses and bacteria in the wet surfaces and clear them out before they can enter our body. So we have to make IgAs to go and protect our wet surfaces. So this is totally fine. And then cytotoxic cells are there. This is what is observed in the Kawasaki disease. This causes the vessel wall to become inflamed, and that causes all of these signs and symptoms. So now let me ask you a question. Isn't this possible that maybe COVID-19 toes may be a result of a similar vasculitis? Correct? Or it is also possible that, remember we talked about hypercoagulability state before. We talked about the hypercoagulability state in detail. Coagulability state, in which there are thrombi forming, and then these thrombi are embolying, correct? They are becoming embolus, and they're going and getting stuck in coronary artery, or they're causing strokes. Maybe they're also becoming small, emboli that are getting stuck in the toes and finger blood vessels. And these are tiny blood vessels, these are fragile, and there are local hemorrhages. So now I want to show you one last thing and then we stop. So here, if you see, this is by an Italian doctor, I believe, and she had tweeted this out, these toes and fingers, which she called COVID toes. So here signs of COVID, purple, red, papules on fingers and toes. So here, and I liked somewhere down here, she had said that it is possible that, let's see if I can find it. So here, abnormal function of our own body cytokines. Somewhere here she has said that this may be thromboembolism or this may be the inflammatory system. And so if I go back here, if Kawasaki disease is triggered again, that may be because there is vasculitis, and that vasculitis could cause COVID-19 toes as well. Similarly, it is also possible that there is thromboembolism and the small emboli are getting stuck in the blood vessels of the toes and fingers, and that is also causing local hemorrhages. So, and this also explains the strokes in the young patients, because the hypercoagulability, and then if they can even develop Kawasaki disease, that means they have a larger vasculitis. They're not getting the hypercoagulable state like adults or disseminated in intravascular coagulation or the septic shock, but maybe they are getting a more milder form. In this context, milder, still it is very bad, a milder form of hypercoagulability where there are emboli going to their blood vessels, including coronary and the cerebral system, causing strokes and heart attacks. So in my opinion, the COVID-19 toes, the cardiac issues, the strokes are actually all connected together because of the immune dysregulation that the children are experiencing. So, so this is the basic discussion. We will stop here, and then I'll talk with the folks here for a few minutes, and then we'll go. So guys, please do me a favor, do share these. So any good sources you recommend that compile an up-to-date list of recent study results related? Not yet. The only good source what I have been doing is that with every video, I have been publishing the links. So now there are about 30 pages of links available for various topics. Maybe we can pull them off of my video descriptions and compile them onto a page. I can help with that if you feel it is interesting, Joseph. Good morning to everyone. Would hemolysis be relevant if not in children, but in, of course, I have done that discussion before. Hemolysis becomes interesting because once the hypercoagulability state kicks in and there are thrombi forming in the body, they are going to consume, they are going to pick up the clotting factors, and then it is possible that bleeding would occur. Although it is rarely seen, but bleeding disorders, bleeding can occur at that time. And with this, remember I had asked you this question in our last talk, that why was the fibrinogen increased? And many students said that fibrinogen was increased because there is a hypercoagulable state. So look, in hypercoagulable state, in the same lecture I had explained that when there is hypercoagulability, then things that are related to coagulation are reduced because they're used up. So fibrinogen will not increase because of the hypercoagulable state, but fibrinogen is part of the acute phase reacting proteins. So excuse me. So when the infection starts and when the inflammation starts, the interleukin-1 and I believe interleukin-6 as well, they trigger the liver to start releasing acute phase reacting proteins, which is C-reactive protein, which contains fibrinogen and many other proteins. So fibrinogen is increased in the beginning of inflammation because of the body's acute phase reaction. It would reduce later on if hypercoagulability state develops. Then all of the coagulation factors would reduce. D-dimers in that case would increase. So if you're seeing that there are no D-dimers, but there is increased fibrinogen, that is an early stage of inflammation. So there is a study done about the immunosuppressions that if you suppress the immune system, it actually, so let me back up for a second. Immunosuppressants, I shouldn't say immunosuppressants, but immune system modulators, let's say steroids, can be given at certain stages when patient is out of danger. But There is a study done where if you give suppressants or steroids, they can reduce the clearing of the virus by suppressing the immune system which is fighting the virus. And that can give the virus a greater chance to linger on in our body for longer time and cause damage. So WHO had actually not indicated the steroids. Is Kawasaki disease possible in adults at all? No. So this is a very, very good question, Chantal. And here is why this question has another memory that came to me. Kawasaki disease does not occur in adults. That means adults somehow develop some sort of an immune mechanism, immunoglobulin, that is against the infections that cause Kawasaki. And they saw that in the younger babies that are still feeding on mother's milk, they also develop less Kawasaki because possibly the immunoglobulins from mother are being transmitted to them in milk and they are safe during that time. So it's a very interesting, what is the exact bacteria or pathogen is not known. So we simply say viruses or bacteria can cause it. But there is something, and adults, being adults, we are exposed to those and we develop those antibodies and we transmit that to our women, transmit that to their children as well through breast milk. And children who are on breast milk are actually better protected for Kawasaki. Very good question, Chantal. Thank you. That reminded me of talking about this as well. Okay, so T cells can replenish intracellular 1-arginine through metabolism. Allowing. So I would respond to that later on. Are there animal models like mouse models that can replicate symptoms? I do not know yet. I'm sure that there are studies going on. I just do not know how many studies. There is so much literature out there. When I start preparing for these lectures, which I can't imagine, people flag them to be banned. Since the morning till now, 6 o'clock, I go over studies, I look at the studies, I read them, I mark the important points, I pull them together into a easily digestible and connected topic, and then I present them to you. So hopefully my service is done, and that is trying to put this together and discuss it together. My request to you is to share it. Now there are actively people who are trying to suppress it as well, so I can use your help. Okay, so colostrum. This is colostrum for everyone. Yeah. So, well, the thing is that adults already have these immunoglobulins. Is lupus a comorbidity? I'll have to check that. I do not know yet. So yes, Carol, breastfeeding is important. It is very protective for the child. Cool. So this is the discussion for today. Thank you very much. We will continue tomorrow. I think we'll talk about asthma and COVID-19. I also wanted to do another latest state of affairs for COVID-19, so we'll talk about that. Please, if you have another topic in your mind, just put that in the comments here. Thank you very much, and talk to you tomorrow. Bye-bye.